You can't improve health outcomes unless you appreciate and understand healthcare providers and patients' wants and needs. I'll give you one example. One of my last companies, I worked on a treatment for Cushing's disease, which is a disease of cortisol excess. And most common treatment is surgery to remove the tumor in the brain that's causing all this excess cortisol. And so it's really interesting. When you ask the surgeons if the surgery was successful, they're quoting rates as high as over 90%. They're saying that 9 out of 10 patients are cured. They're better. However, when you ask the patients, was it successful? They're quoting rates that are dramatically less, often less than 50%. So why the big disconnect? From a surgeon's point of view, the measurement of success is focused on whether they remove the tumor and disrupt the cells, whereas the patient was focused on, do I feel better? The reality is they're both right. But understanding what's most important to patients and healthcare providers and bridging that gap will ultimately lead to better outcomes. So if we don't understand the patient's perspective, we may be assessing the quality of care through just a single lens. And in my view, we really have to look at it through the perceived benefits of both. So to me, it's my really call to action of we've got to be more involved. It really makes a difference. We are so uniquely positioned to make that impact. And I know typically medical affairs doesn't lead it, but I'd really ask you to raise your hand and show the value that you can provide. But more importantly, how do you take those insights and apply it to medical affairs?
So as we start our next expert panel about how we can revisit those operations, those details that matter in pharma and biotech, also taking two different perspectives, both a global health system perspective, as well as a commercial and pharma and biotech perspective from our two speakers and leaders here, who are some of the most hardworking and dedicated individuals that I know, Dr. Rashad Massoud and Rob Adamoski. Rob is an executive with extensive experience leading teams at Gilead and hepatitis, both market access, commercial, marketing teams. And he is the type of leader that it creates the environment of professionals who ultimately deliver results and who leaves a mark on our healthcare. Most recently, he was the Senior Vice President of Prevention Bio, and he currently serves as Vice President of Medical Affairs at Corcept Therapeutics. We'll also hear from Dr. Rashad Massoud, who is a globally recognized healthcare quality leader, visiting faculty at Harvard School of Public Health. He has helped various different health systems across the globe implement initiatives, quality improvement initiatives, and scale them at large. He's been an advisor at the World Health Organization, also is an inaugural member of the International Society of Quality of Healthcare, has led large global initiatives at AmeriCares, USAID, and he has traveled to over 104 countries and worked with 93 different health systems. And so what connects them both, again, is delivering those results and inspiring teams to improve our healthcare quality. I'm very excited about both of you. Welcome formally, Rashad and Rob, to the Olympics.
Thank you. It's an honor to be here.
The panel is titled Sprint and Long Jump to Leave a New Mark on Healthcare Quality. Here's our outline of the discussion. As I mentioned, we'll have both a global health system view as well as an industry view. And we'll also talk about our accountability in pharma and biotech and in healthcare systems, making that global impact of medical affairs on our healthcare community more certain as we leave this meeting and also panel. Rashad, I want to start with you. You have worked in 104 countries, as I mentioned. You're quite familiar with a wide range of health systems as well as their gaps. Can you share a successful quality improvement initiative and some of the factors in their outcomes?
Absolutely. So let me start by just sort of mentioning, when we say quality improvement, quality of care, what are we referring to? To me, I'm trying to just put it in a nutshell. Quality of care is really about being able to deliver the best scientific evidence that we have the accomplishments that we have through science to every patient or person who needs it every time it's needed. And when we say it's a function of delivering the best evidence, I mean by that in a safe way, timely way, contextually appropriate way. Now, the scientific accomplishments we're talking about are basically the diagnostics, the pharmaceuticals, the skilled interventions that we have. I'm going to generalize them in a term that I call discovery. So a lot of, the pharmaceuticals, a lot of the diagnostics that we have, the things that we do in that, I'll use the term discovery for that. And then getting them appropriately to every person who needs them is a matter of who does what, when, how, what are the handovers between them, whether we're talking about health workers, physicians, nurses, etc., patients, families, community, and all of that I'm going to put under the title delivery. So throughout my conversation today, I'll be talking about discovery, I'll be talking about delivery, because for me, as somebody who specializes in the area of quality improvement, I recognize that these two entities need to come together to produce the best outcome that we are seeking. In terms of an example, I chose an example that might resonate with you. It's from a while ago. I'm going to take you back, like 20 years back when antiretroviral therapy for managing patients with HIV and AIDS was discovered and was made available. The idea was, we want to scale it up to all the patients who need it. It still is a life-saving drug, and many patients with HIV and AIDS were not making it because of the lack of availability of the treatment. Now, the situation at hand was not only patients weren't getting it, but we also, as we started to scale it up, we discovered that not every patient that we give it to stays on the treatment. The term that was used then was lost to follow-up. That is, we don't know where they are, we don't know what happened to them. And of course, the clinical outcomes were not as good as they could have been. People were still dying from HIV and AIDS in large numbers. So what did we set out to accomplish? We set out to put those that need treatment on treatment, to keep those that have been started on treatment taking their treatment regularly, and those who are taking their treatment regularly should be doing well clinically and physically. So the slide that we have right now in front of us basically is what we call a time series chart. A time series chart is an indicator over time, and this particular one is for 5 health centers from a district in Uganda called Bwikwe district. The indicator is on the y-axis, and that is a count, the number of patients. And as you can see, it goes from 0 to about 8,000 plus patients. And the x-axis is time, and the time is measured here in months because it's an aggregate time series chart. Now, it looks like a complicated chart, but let me just quickly go through it and explain what it's showing us. At the very top of the chart, you see a blue line. That blue line is an estimate of how many patients in the community served by these 5 health centers need to be put on ARVs. And as you can see, of course, over time, that number was growing because the outbreak of AIDS was still increasing. The pink line underneath it is a line that basically tells us how many patients were ever started. That is, somebody was put on treatment, we registered them. And as you can see, when we started, there was a coverage gap of about 44%. That is, 44% of those that we thought should be on treatment are not on treatment. Then there's like a midpoint at which, or approximate midpoint at which that was brought down to 19. And then, of course, that gap was bridged almost. There's a blue line underneath the pink, a light blue line. And that basically subtracts out anybody who has legitimately transferred out. That is, some patients did not make it, and some patients are receiving care elsewhere. So we take them out so that we get a more accurate representation of who should be on treatment. The yellow line is the number of patients that are regularly presenting for their care at the health center. And as you can see, we had, and that's called the retention gap. How many of our patients are retained in care? You can see that it started with a 49% retention gap, which was reduced to about 24% at some point, midpoint, and then down to 5%. Below that is a green line, which basically is a measure of those doing well on treatment. And as you can see, about half of the patients were doing well on treatment, 53%. And over time, that went down to 24% and then 5%. And all of this was happening while the numbers went up from about 6,000 to about, or just under 6,000 to just over 8,000 patients who are requiring the treatment. I also want to mention that there's a faint dotted line, which is vertical. You can see that. It's a broken up line. And that basically was the end of the technical assistance that we were providing as an organization. Our funding ran out and we were no longer able to provide them with technical assistance. But we were still in the area, so we were able to get the data and see what was happening. And that from that line onwards, the health center teams were working independent of inputs from us. I'll come back to that later in our conversation as we talk about human resources. Now, what can we see on this graph? We can see that we have an efficacious treatment that can save lives, and it is available, but it does not mean that every person who can benefit from this treatment is benefiting from it. And even those that are started are not necessarily continuing with it. When we talk about healthcare outcomes, it's not just about the discovery part, the availability, the drugs and their availability. It's also about the delivery and all the issues that happen in the delivery of care. And that is rooted in context, in systems, and psychology, and all the interactions that happen in this system. So let me now talk a little bit about how we did this. And again, you will see that this links up with some of the conversations we're going to have a little bit later on. First of all, how did we do this? We were clear on the aim. We had 3 aims: get patients on treatment, keep them on treatment, have them do well on treatment. That's what we set out to accomplish. To do that, what we did was we brought in multidisciplinary teams of healthcare providers, all the different actors in the healthcare delivery system that need to come together to be able to deliver this good care. We also brought in patients to help us understand, and their family members, so that we can redesign the system in a way that caters for all of those needs. Now, we discussed barriers. Why are patients not coming in? Why aren't they staying on the treatments, etc.? And some patients said we weren't able to come in because we're not feeling well. So in some ways, we either went to them or brought somebody or allowed them to send somebody on their behalf to get the treatment if they were already started. One patient I remember distinctly being in one of the health centers, and one patient said to me, I was in the waiting area. My neighbor walked in. And of course, her neighbor didn't know that she had HIV. And so she had to leave. Otherwise, the patient, her neighbor, would see her walking up to the HIV clinic, a certain door that people knew was for HIV/AIDS patients. And so with that type of knowledge, we actually had to create a separate waiting room in order to cater for things like these that are happening quite more often than we think. So this is about having the efficacious treatment, but also making changes in how we deliver the care in order to get the results. And if we get a better result, then we basically keep it. And if not, we either change it, modify it, or we discard it, because what we don't want to do is build in unnecessary redundancy. We keep iteratively doing that until we get the result that we want. And of course, we document all of this. Now, these changes are contextual, but a lot of the underlying principles that are behind them are quite universal. So, for example, a patient who's not feeling well to come to the clinic, a family member may pick up, or a health worker may visit them, or we could give them a referral to a hospital. This work that I'm describing is published in the AIDS Journal, and I actually presented it at the AIDS conference in Australia at the time. Now, you might ask me, how is this relevant? I'm aware that, particularly in the pharmaceutical industry, that many of the treatments, the diagnostics, are not taken up by the healthcare providers or by the patients as much as they should be. So much intellect, energy, time, money is invested into the discovery part. But by taking the extra step to address the obstacles and figure out solutions to the delivery, we can really put those to the benefit of the patients who need them. And of course, it's a very strong business case for increased uptake of the things that can benefit, the discoveries that can benefit patients. I'll stop here, Tim, and that sort of, I hope that was an example that illustrates how we can improve quality of care, both working on both the discovery and the delivery aspects.
Absolutely. So I think it's a great start in distinguishing discovery from delivery to those patients who need our innovative products. And so I'd like to now ask you, Rob, for a perspective from pharma. What role can medical affairs in pharma and biotech play in results that we just heard from Rashad?
Yeah, Tim, and thank you so much. I really appreciate Rashad. That was just awesome. And really the whole goal of my part of this panel is really to focus in on three themes. One, trust, relevance, and collaboration. I think that's the hallmark of making a dramatic improvement in the quality of healthcare delivery. As Rashad mentioned, it really takes a village to make it happen overall. When I really think about what can we do as medical affairs professionals to really help drive that change, first I think about building the team. What is the composition of the team? Really with a goal of delivering education, offering perspectives that are clinically relevant, and establishing trust and relationships with healthcare providers and the patient community. And so how do we do that is really the question. So the first thing I focus a lot on is connection to a therapeutic area. Are you hiring people here because it's a good paycheck, they like the company, or is there a deeper sense of purpose of why they're here? Do they have this personal connection to the disease or what you're doing? This sense of purpose is so critical, because if you genuinely care about something on a deeper level, your passion is going to come out in what you do. It allows you to be better to handle the ups and downs of our jobs, which, as you all know, there's many. And it helps you, limit getting discouraged when things get really tough. Also, it's one of the many variables that I think is helpful in establishing a trusting and collaborative relationship with healthcare providers and patients. And not to mention, as Gary mentioned in his presentation earlier, passion is contagious. It really is. You want to be around people who are passionate about what you do. And when I think about the realm of our job today, during COVID and post-COVID, it's harder and harder to capture the attention of healthcare providers. It's actually more and more difficult to really carve out time for really in-depth conversations. So when you have people who are passionate about a disease, it's something people want to talk about. They want to talk to you. They want it. They get excited themselves. And I'm not saying that every single person on your team should have a connection to the disease, but I really promise you, if you just have a few, it'll make the whole team better. The second point, it's a bit controversial. Again, I'm a bit of an atypical individual in this industry, but honestly, in all my years of experience, the most effective medical teams, particularly the field medical teams, they had a balance of industry veterans and people with recent and relevant clinical experience. If the majority of your team is industry veterans, how do you know what they're talking about is relevant? Sure, they can recite all the emerging literature, but I'd argue that having individuals with recent and relevant clinical experience will offer for additional perspectives on translating the emerging science to what's clinically relevant. To be effective, we need to take all the data that is out there, and not just communicate it to our target audience, but really communicate it in a manner that's relatable to the audience and also to the clinical care environment that we work in. Finally, I think having a team composed of healthcare providers and medical training that is relevant to the therapeutic area you're working in. So if you're working, like as Gary Hall mentioned, if you're working in endocrinology, make sure you have people with relevant clinical experience from endocrinology. This is so critical, and far too often, I see medical affairs teams with all PharmDs. And I'm not saying that PharmDs are not great at their role. But when I look at the care continuum, PharmDs are clearly a very important part of it, especially when it comes to drug selection, administration. But as you know, they don't work alone. Having a team that's composed of doctors, nurse practitioners, PharmDs, and PhDs collectively will have a much better appreciation of the care continuum and what each party can do to make a meaningful impact on the quality of care. If your staffing of your teams over-indexed in one type of HCP provider, are you sure they're delivering the best possible information in a manner that's really appropriate to the audience? Some of the folks I worked with in the past know when I was at Prevention Bio, we took a pretty extreme position on this, that everybody on a medical affairs team either had to have a connection to the disease, was a clinician who treated it, or was a researcher who dedicated their life to understanding and advancing the science behind it. And this is really important to us because we're an unknown entity. Nobody knew who we are. We had to make a fast start, and we needed to have that inherent trust and credibility to really get off to a fast start. And we did this all during COVID, and honestly, our access was unparalleled to other companies. And people always ask us, like, how are you getting in front of doctors? How are you making this difference in the COVID world? Is because of that. And my final point here, it's balance. What is right balance for you? Hey, there is no magical formula you can plug in, but there's a couple factors that you want to consider. What stage of the product life cycle are you in? Is this truly a novel treatment or one of many drugs in the class? And also, how complicated is the disease and treatments, and what are the biggest medical challenges? So what I really ask the team is to think differently. In medical affairs, we tend to have a very clear roadmap of how we do things and also who we hire. And not saying we should not follow it, but also it's okay to break the rules occasionally. I really think as you bring in unique perspectives, if we really want to make a difference in healthcare delivery, you have to have clinicians, patients, and medical professionals all working together to make a market difference. Tim, I'll turn it back to you.
Sure, Rob. And you reminded me about your approach in which medical liaisons, field medical liaisons, had a chance to train the entire executive team at Prevention. Am I correct?
No, that's totally true. I mean, I look at that as two things. Tim's going to go into in a second of talking about how do we improve the metrics of the organization. What I focused a lot on is maybe my marketing background. I spent a lot of time communicating to the executive team the merits of the team, but also whenever I could, I would put my team in front of the executive team. So any new executive who was hired had a personalized medical affairs trainer that supported him through the journey. Instead of putting him through training or give him a couple of papers, everything was personalized to them. And I'll say it was really interesting. On the very last day of Prevention Bio, after the Sanofi acquisition, the CFO called myself up and a medical scientist who is his personal, disease and product expert and said, guys, I want to thank you. It was one of my first experiences at Prevention Bio. And honestly, I've been in the industry for so many years, and I love to have somebody there to personally walk me through it and to really help me be successful in my job. But also the inherent benefit to us was he saw our value beyond a dashboard. He saw our value beyond just the hard metrics. He saw it firsthand what our team could do and the contribution we can make to the company, but also most importantly, our patients.
Yeah. Thanks, Rob. And one company in which both of us have worked in, where you were a leader at Salix, also was a great example on the field medical team, where we went back every month and we contributed to a publication, to a journal, the MSL journal, that was distributed to everyone in the company, including the CEO, which forced us to learn, to continue to learn, and also develop our skills. Here's some data on talent management and a particular gap, which I think has important implications on our accountability. to what extent are we able to provide that quality information to our healthcare providers who are responsible for innovating and helping us live longer? This is a recent benchmarking study of over 64 companies, medical affairs teams, that shows that only 42% have a formal talent management program. Now, granted, there could be approaches that may be somewhat informal, but this may be an index of a particular gap, right? And it seems like the larger companies are doing this more extensively and better than some of the smaller companies. And this is why the example that Rob, I think, has shared in a relatively smaller company is a very unique one, and it makes an important point about about training and the value of training our internal teams. So training is also one way to measure our impact, all right, through our on healthcare outcomes. And you're right that metrics are often seen as dashboards, and I think Gary mentioned this somewhat. He alluded to it earlier in our discussion that the R&D and in our medical professionals, the outcomes of our medical contributions are not often seen until much later down the road. Nevertheless, we cannot really improve something that you don't measure systematically. So this was a hypothesis that we had at Amadev Pharma, that after the surveys that we had done, that had consistently shown that our colleagues, our healthcare providers in the pharma and biotech industry have a understanding of the purpose in all healthcare outcomes. However, only 5% of them find the metrics with which their contributions are evaluated meaningful. And so no one is really excited about metrics. However, you need them to communicate our value, particularly in our environment today. And so in typically we measure our contributions based on how many physicians we see, how many publications we release, or how many standard medical information responses we send to our healthcare professionals with questions or with inquiries. However, are those activities or are they outcomes? So our hypothesis was that the majority of the KPIs that we report are just absolute numbers. They're, however, a publication may be an activity for the publications department in medical, but it may be an outcome for field medical affairs, for example. So what we report is typically our guesses or exploratory endpoints for how you would want to scale those successes. However, we very rarely incentivize our teams to also report negative outcomes, or we don't always follow through on whether or not that particular medical information letter was relevant to that healthcare professional or to the patients that they see, and whether or not they improved their decisions. We don't have time to do that because of how busy we are and how committed we are to showing our value to our external customers. And so this leads to an example where a metric does not fall on that line. It doesn't describe that relationship between activities and outcomes. So it's only when you introduce a feedback loop, when you systematically report both activities and outcomes and distinguish ones from others, list them and grade them, if you will, in different value, that you're able to more accurately describe how that metric may predict and validate also success in the future. So in this data science kind of analogy, what we can approach metrics as is three different grades of metrics, which correspond to just capturing data, right? So trends that we collect through predictive analytics as well, level 2 metrics, or through prescriptive metrics that don't only tell us the correlation or the description of trends, but that tell us whether or not there's a cause of that one particular activity. The reason that physician improved their decisions was because they met with that medical liaison. So we tested these hypotheses. We designed this study as Amadeus Pharma together with the Medical Affairs Professional Society, and we were able to validate this gap. It showed that most of the companies in pharma, in biotech, in medical affairs, in fact, 70% do not have any methodology in place to analyze that relationship between activities and outcomes. As you can see, 70% do not have this methodology in place. In a survey of 51 global companies. Now, I think we also need to talk about why we measure our performance as well. And based on some of the results, it seems like we measure our performance in order to validate our value, which we already inherently know, for internal stakeholders, from commercial, from others, or to drive high quality performance, which are all important reasons and rationale. However, we very rarely communicate our value to external customers, the very customers who directly are impacted by our performance. And so that is one particular gap. And what has led to a model, a framework called the Medical Productivity Index that I've written about before and I've presented to large global medical affairs audiences, which allows us to list the activities, rank them, assign them a particular numerical value, and then reward performance behavior equally, and also distribute accountability externally and internally as well, in a balanced model that allows us to understand the meaning of our work, and also that eliminates some of the skeptics who may clearly see the purpose of their work, but they may not really understand or agree with how they're being evaluated or the meaning. So this is some of the approaches that I've spoken about and that we've tested very successfully in startups before, Rashad. What particular systematic approaches you've used to drive those successes in quality improvement measurements on a healthcare system, from a healthcare system perspective?
As we discussed, one of the examples I'm going to use illustrates several of the points that Tim brought out, and I'll go through them as I describe the example. In this particular piece of work, we set out to improve care for patients with hypertension. We also had a strategic direction at AmeriCares where we did this to bridge any inequity gaps should they exist. The work was done in India with 8 mobile health centers. These are like vans that are fully equipped, go around and serve people in slum areas around Mumbai. And then our aim was clear: improve hypertension and bridge inequity gaps. The team that we put together are the healthcare providers for each van and a selection of the patients that are being served by that van so that we can understand what's happening there. Now, we're talking about key performance indicators. So the first one very clearly was, how do we know that we've improved care for patients with hypertension? Well, the measure we decided to use, readily available, is percent patients with controlled blood pressure. So if a patient is coming and their blood pressure is within control on treatment, then they're classified as controlled. If the blood pressure is outside of those parameters, then they're not. And we're taking the percentage at every visit. Now, in order for us to address inequity, we first of all had to uncover inequities. So the way we did that was to look at, amongst the patients that we're serving, can we identify any potential inequities? So we looked at geography, different areas, we looked at age, we looked at caste, we looked at gender. Of those potential causes of inequity that we could think of, there was only one that showed an inequity gap, which is gender. So that became our second KPI. Now, the time series that we have in front of us basically is for all 8 mobile health centers combined. And what it shows is the indicator, which is on the y-axis, percent patients with controlled blood pressure over time, and the numbers that you see are the weeks of the month for every weeks of the year for every month that we have. Now, if you look at this graph, the black line is the total number of patients whose blood pressure is controlled. The red line are the females whose blood pressure is controlled, and the blue line are the males whose blood pressure is controlled. So both the red and the blue are subsets of the black line. And if you look at the beginning, when the intervention started, basically we had about 62% of our patients with controlled blood pressure, and there was an 11.5% gender inequity gap. Those are the two parameters, the two KPIs we are trying to address. And so we started a series of conversations with patients, trying to understand potential reasons why their blood pressure is not controlled. We tried to test different changes in order to address those inequities. And over time, you can see that the results moved from, and they weren't exactly linear, and I'll say a couple of words about that in a minute. They went from 62% blood pressure control all the way to 91% of patients with controlled blood pressure, and the gender inequity was reduced from 11.2% to 2.5%. Now, that's despite 2 COVID lockdowns, which interrupted the work. And as you can see, during the COVID lockdowns, there was very little happening. So this is the sort of work that you do. The yellow line is basically the median for all of the data. And essentially, there are what are called run chart rules, time series chart rules, that basically tell you if there's a certain number of points above or below the median, then that is a statistically significant result. So we have a statistically significant improvement that is actually sustained over time. If I can go to the next graph. Now, this is where Tim was talking about, we don't talk about the things that don't work. Well, as an improver, we actually need to study both what works and what doesn't work. This chart here is for one of the mobile health centers. They arbitrarily named their mobile health centers after the zodiac sign. So this one is Aquarius, and it serves a particular area around Mumbai. And basically, the reason why I'm showing you one time series chart, you can see a similar pattern where there was a statistically significant improvement in the data with a bridging of the inequity gap. But the more important reason why I'm showing you this is because you can see these lines with writing, we call them annotations. What is annotated in brown are changes that did not work. What is annotated in green are changes that work. So if something didn't work, we have the option of modifying it or discarding it. We don't keep it because that's a redundancy that's unnecessary. If it is in green and we're satisfied with it, then we keep it and we move on and test other changes. You can see we're testing iteratively, one change at a time, looking at the results, seeing if they work or if they don't work. Of course, a lot of this is contextual. Now, remember when I was talking about the ARV example, I also mentioned that we document this. So this is documentation. Now, the table that Tim just brought up is basically a table that shows the results for all 8 of the mobile health centers. You can see the names at the top and the different changes that are tested, and those are in the first column. What is in green with a check mark are changes that worked. What is in an orange color with a cross on it are changes that did not work. Now, it's really important for us to learn about what doesn't work as well as what works. And as you can see, there are a lot of, some changes will work almost everywhere, and some changes will not work anywhere, and some will be a mix. Imagine if a 9th mobile health center existed and we wanted them to do this work, or some other place wanted to do this work. We could share this information with them And instead of starting from zero, they're starting from 80, 90% of the work done. And all they have to do is think through, I think this would work for me? They test it and so on and so on. So learning from what doesn't work is just as important as what does work. Now, Tim asked me for, what is the systematic approach to KPIs? The first thing is there has to be a theory of change behind it. So our theory of change is grounded in discovery and delivery. There's the right treatment that needs to be given and how we deliver that treatment. The second thing is that we're focused on what really matters. And what matters is the outcome of care. So essentially for us, there are two outcomes here: controlled blood pressure, which has a series of other very important outcomes, and then bridging inequity gaps, which is important. Now, there's a lot of activities, and we do measure the activities insofar as did they work, did they not work, but that's not where we keep our eye on. Our eye is on the ball, on the outcome of interest that makes people healthier and improves care for patients. I'll stop here. I'm happy to answer any questions.
Sure. Well, thank you for taking us through your approach, and I think it inspires us to consider something that is not as empiric as what we have been kind of forced to succumb to, but something a little bit more scientific and something less ad hoc but more iterative, as you mentioned as well. And so, I'll share just a few other details here from this benchmark report that again shows that about a third of the companies really do not distinguish between the activities and outcomes, which, as you saw, Rashad had delineated very, very clearly. So the outcomes in the application that we used in one startup company were also clearly defined as the ones you see here. One of the reasons I think that many of us do not feel that the metrics are meaningful is because we don't also map them to the goals, right, to the objective category. And you need to be able to do that systematically in one function at a time. That's our approach and our hypothesis once again. So Rob, the ultimate result of delivering information and generating new information is, of course, to improve healthcare decision-making. And in the letters that go out usually to physicians, we clearly state that we don't provide treatment recommendations, yet paradoxically, our ultimate value is in helping improve those decisions. What are some specific highlights of medical affairs teams that have improved these decisions in healthcare?
Yeah, Tim, and again, my response is really aimed at what can we do as medical affairs professionals. And a lot of times in medical affairs, we use the term knowledge is power, and that certainly is true. But I would also argue that perspective of the healthcare provider and the patient is equally as powerful. If we don't understand what's important to each one, I think we may miss the mark. So with that being said, one of the things I'd like to see medical affairs team do more of is leading patient advocacy engagements. And I think really the emphasis here is lead. In most companies, medical affairs is part of these engagements, but the role is really supportive in nature. I'm not saying that commercial or other teams cannot be involved, but I really feel that medical is more connected to disease and to science, and most individuals are healthcare providers. And this comes back to the concept of being able to provide relevant conversations and building trust. The benefits of leading these engagements is we can now pair our knowledge of the disease and our products with a patient's perspective. This truly gives us a 360-degree view of care. In my opinion, this is invaluable in creating educational content and programming, leading to better health outcomes and quality. You can't improve health outcomes unless you appreciate and understand healthcare providers and patients' wants and needs. I'll give you one example. One of my last companies, I worked on a treatment for Cushing's disease, which is a disease of cortisol excess. And most common treatment is surgery to remove the tumor in the brain that's causing all this excess cortisol. And so it's really interesting. When you ask the surgeons if the surgery was successful, they're quoting rates as high as over 90%. They're saying that 9 out of 10 patients are cured. They're better. However, when you ask the patients, was it successful? They're quoting rates that are dramatically less, often less than 50%. So why the big disconnect? From a surgeon's point of view, the measurement of success is focused on whether they remove the tumor and disrupt the cells, whereas the patient was focused on, do I feel better? The reality is they're both right. But understanding what's most important to patients and healthcare providers and bridging that gap will ultimately lead to better outcomes. So if we don't understand the patient's perspective, we may be assessing the quality of care through just a single lens. And in my view, we really have to look at it through the perceived benefits of both. So to me, it's my really call to action of we've got to be more involved. It really makes a difference. We are so uniquely positioned to make that impact. And I know typically medical affairs doesn't lead it, but I'd really ask you to raise your hand and show the value that you can provide. But more importantly, how do you take those insights and apply it to medical affairs? So, Tim and Rashad, I'll turn it back to you guys.
Yeah, thank you, Rob. I think that was a great example and a comparison, I think, of the perspectives and the reality. Rashad, I know you are a physician and you've dedicated your career and life to improving quality of care, and you emphasize delivery. And a lot of big part of that delivery is the affordability, right? The Inflation Reduction Act, and the balancing that, the affordability with innovation in order to make sure that we don't threaten and hamper innovation. Can you share with us just some of the latest trends in that cost and quality relationship in healthcare?
And by that you mean here in the US?
Here and globally as well.
So the relationship is not a direct one, I have to say. However, we do know that there are some minimums that need to be invested by different in different places to be able to achieve. If we underinvest, then the likelihood is the outcomes will not be good. But then beyond a certain level of investment, which seems to be around anywhere from the 5 to 7% of GDP mark, it becomes less clear what is the relationship. When it's below that, clearly the system is under it's not enough. Now, the US, for example, spends 19% of its GDP on healthcare, about $30,000 per capita per annum. And when you compare that to other developed countries, they spend anywhere from 8 to 10. Most of them spend anywhere from 8 to 10% of their GDP, about $6,000 to $8,000 per capita per year. That's a huge difference. That's double the amount. And in terms of quality of care overall and on certain individual parameters, the US does not rank any higher than any of the other countries that are investing half as much. And even some of the upper middle income economies are actually getting better results. So I think we need to take the amount of investment with a grain of salt and look at two things. First of all, the efficiency of care delivery, which has a lot to do with it, but then also the equity of care. Because if we start to look at, are we delivering, all of this investment, who is it going to? That starts also, and what types of how are we spending that investment? That determines a lot. A lot of investment in the primary care systems and in preventive care seems to be giving us much better results than an emphasis on acute care and on what's called rescue care. If you're going to have a heart attack, have it in the US. That's the best place to have it. But if you have diabetes, don't live here. Go somewhere else, where they actually have investments in those areas. That's the type of thing that I'm referring to. And I'm generalizing, of course.
Thank you, Rashad. So I mentioned earlier that you're also a physician. And I shared some of the striking statistics earlier in the opening. regarding the healthcare shortage, right? That is expected to exceed over 3 million in very few, a few years, and which is driving also the costs of healthcare higher, the premiums as well. And also it's leading to less time to train on the new exciting technology that we will talk about later as well. And it's also making it more difficult for pharma and biotech, like Rob mentioned, to engage with healthcare, to educate them. And so how can we make healthcare jobs more desirable? Very complex question, but I want to,
Sure.
I'm curious about your opinion.
Actually, Rob really put his finger on it. And, let me give sort of a similar perspective to what Rob was describing. I'm a physician. I didn't go into healthcare because I don't care. I actually went into healthcare because I do care. And I know that pretty much everybody that I know, that's the reason they went into healthcare. Now, what happens is when they are, in the healthcare delivery system, they get entrapped into things that don't really allow them to do what they came in to do. There's a lot of bureaucracy, there's a lot of writing, there's a lot of different things that really don't get them to do that. Now, they went in to save lives, to alleviate suffering, to help people. That's why they're in that, and a lot of them get frustrated, they leave, and they find the jobs undesirable, and they move to other things. Now, if we understand that as a causal system, and then we enable them to do what they came to do. I mean, think about the ARV, the antiretroviral therapy example I gave you at the beginning. That's why I clearly pointed out that dotted line in the middle, vertical line in the middle, where our technical assistance ended as a foreign project, and that work was continued by the health workers on their own. And they continued to get amazing results. Now, all they need is to see a way for them to be able to do what they went into the care profession to do, and they jump at it. They love it. So I think we should think of all the, as we design work, as we implement work, we should think about how do we keep them engaged in the very purpose, the values that brought them into this system. And that way we're going to retain and we're going to get much better results from health workers.
Great, Rashad. So we're getting some comments here from Andy Cagle. And as we wrap up, I want to ask you both one question. And since the title of this panel is a sprint and a long jump to leave a new mark on healthcare, in maybe 1 minute to select one of these two elements of accountability and transparent data culture with a final message to our healthcare audience of how can we leave a new mark by increasing our accountability or integration of data? Rob, maybe I'll start with you. Please, if you can comment on our accountability on healthcare quality.
I'm not sure if people are going to like this response, but I'll give it a try anyways, because I definitely want to try to be provocative, and it's really how I've always taken on my career. But mine, it's like, don't be held accountable to always follow the well-worn pathway and process of how we do medical affairs in pharma and biotech. I'm not saying we're doing a poor job, but I also feel like we're investing so much and we're getting to the point of diminishing returns when it comes to outcomes and improving quality. Our improvements right now, honestly, are small and incremental. I dare you to think out of the box, and don't be afraid to bring in talent that has been atypical and to foster creative thinking and ideas. As we welcome more fresh ideas, hopefully lead to better outcomes. Really, I think about it, it's so critical that we match the innovation that our colleagues in clinical development are doing, right? There's more and more innovative products coming out every single day. And as innovation expands beyond the classic nature of clinical care, we need to also be innovative and think creatively. So it's my call to break the rule book a little bit. We don't want compliance on our back door, but I think be thoughtful, be creative, and don't always follow the blueprint. I know it's scary, but I guarantee you we'll stumble a little bit. But I really think in the long run, we're going to make such great strides that will really ultimately make us feel really happy with the advancements, but more importantly, the translation of those advancements into clinical care. And that's where medical affairs is instrumental. So I wish you all the best luck, and I'll turn it over to Rashad.
Thanks, Rob. So I'll talk about data integration and the transparency data culture. Well, I think the two examples that I've shown, and pretty much every other improvement activity I've been involved in, has been very much based on data. And the data tells us where we are, tells us if we're making progress, allows us to navigate through all the different changes, whether they work or don't work, and allows to tell us, they tell us whether we've reached what we wanted to accomplish or not. Without this data, this work isn't possible. And notice I'm talking about data in real time. So it's not like I come in with a bunch of changes a priori and I just implement them. I'm testing one at a time, looking at it, seeing if it works, if it doesn't work, etc. Time series charts are just amazing. And guess what? It's not just me who's using them. It's not just the technical assistance group. It's the health workers themselves. And they love them because they can actually see the effects of what they're doing in real time. They test today what a physician or a nurse or a health worker tests a change. And in the next few days, they're looking at, has that change yielded the improvement they thought it would or not? And of course, this is what transparency is about. And then also, aggregating all of this data and tallying up what works, what doesn't work. That's transparency. And the fact that it didn't work with me does not mean that when Rob tests it, it's not going to work with him. But us sharing the information and being transparent about what worked, what didn't work is really critical. So to me, data integration and transparency about the data is critical in this work.
Thank you, Rashad. Well, we have some comments here and a lot of gratitude from Andrew Cagle. Here, he emphasizes the importance of patient advocacy from your points, and also Rashad, about your point of healthcare in the United States with heart disease and chronic disease as well. So I want to thank you both for truly inspiring your teams as you have led them in healthcare in different aspects and facets of healthcare throughout your careers to deliver those results and to inspire many of our audience here to break the rules and to be a little bit more scientific and systematic as well. So thank you. Thank you very much.
Thank you, Tim. Thank you, Rashad.